Hi, good morning, everybody. Welcome to this public briefing. There's a lot of you here, which is great, and I'd just like to start. A number of you come to most of our board meetings and public briefings, and some are new faces, which is always good to see. And I just wanted to start by just saying a couple of words about the. Sorry, you can't hear. Okay, sorry. I'd just like to start by saying a couple of words about the public briefing and the way we work, because over the last few meetings, we've had a lot of interesting debate between members of the public and our executives, but sometimes the tone of the debate has got a little bit unfortunate, I think. I mean, what we are here for is to answer your questions. So what we like is for you to ask questions about anything about the Trust, and we will do our very best to answer them in as frank a way as we can. But in a few recent meetings, we've had a few political statements, we've had quite a bit of shouting and so on, and things which might have been interpreted as impugning the motives of some of our execs. So some other trusts insist that for their public meetings that all questions are sent in advance in writing and then just answered like that. And we don't want to do that at all. We much rather have a debate. So we don't want to do that at all, but we are just sort of reminding everybody of some guidelines. So very simple. Everyone obviously should conduct themselves in a courteous and respectful manner. The questions should be asked to me as the chair, and then I will refer them to the appropriate exec director, whether it's Daniel or Ruth or Arlene or whoever else is around the table. The questions should be just that. They should be questions. They shouldn't be statements, they should be questions, they should be focused, and they should relate to what we've been discussing. The executive who responds to the questions should basically be allowed to finish their answer without being interrupted, and everyone in the audience should have the opportunity to ask a question. So as chair, I want to make sure that everybody gets an opportunity. So I won't come back to people who've already asked a question until all the people who haven't asked a question have had an opportunity to ask it, if you see what I mean. I'll also indicate at the start of the session how much time there is, so that we all know when we're going to start and finish. So hopefully they're all fair and reasonable, and that's how we'd like to take it forward. So without further ado, on with the meeting. It's Ruth first, isn't it? Yeah, okay. Ruth, thank you.
So as usual, I'm going to start by highlighting some key aspects which are on our integrated performance report, starting with the safe and effective mortality domain, and really to highlight an ongoing very green and positive picture there with low HSMR, that's hospital standardised mortality ratio, and SHIMI, and a mortality review process which has been increasingly embedded in the way we work in the organisation. Going on to page 2, I want to highlight a couple of issues that have emerged at previous boards. One is that we had, in the previous month, had difficulties in assessing our higher risk patients with TIA, that's patients who are at risk of stroke within 24 hours. Our performance has improved in month, although at St Helier we're still at 50% rather than the threshold, which should be 60%. And we're having ongoing conversations with GPs through the CCG to make sure that GPs know that we've got a service for patients to be seen urgently, and encouraging GPs to refer patients in rapidly to that service should it be required. We continue to be challenged in terms of our delivery of screening for both VTE and dementia. The whiteboards now are in place and were helping with VTE, so we are refreshing the steps that we need to take in order to drive that performance up. They are not yet showing the dementia screen, so I would not expect that to have had an impact at this stage. The final point I want to highlight on 1.3, this is where we report the incidents, adverse incidents that have been reported as an organisation. What I want to highlight is that in the month of March, which this data set pertains to, the Trust actually submitted the majority, so 80% of the serious incident investigations in a timely way. Those of you that have been at the board through the winter months will know that has been a particular struggle to get the incident investigations done in a timely way at a time of peak pressure. And I'm pleased that the March position shows an increase to 80%, but will not be satisfied until we're back at 100%, which is where we've ordinarily sat. So those are the key points I was going to highlight from those domains, and I'm then going to hand over to Arlene to talk about safe staffing.
Yeah, and so in terms of safe staffing, we continue to be quite green in terms of the quality of care being delivered, which is measured by Safety Thermometer, which is a national tool with 98.2%. In terms of the staff on the wards, our CHPPD, which is the care hours per patient day, measured by the total number of staffing hours we have against the number of patients in bed, that's gone up to 7.5 this month. And like everywhere else, we're challenged with the number of registered nursing staff. However, as the reports shows, we are using quite a number of unregistered staff to support entire numbers on the wards. And we're also using our ward managers. We aspire to have them 50% supervisory supporting staff on the ward, but if there aren't enough any staff, then they have to go into the numbers and work alongside their staff. In terms of infection prevention and control, we ended the year with 5 MRSA bacteremias against the previous year, which was 6 or 16-17, and we've had none so far this year. C. diff, we ended with 40 last year, and that was against a trajectory of 39. And we are looking at, we have implemented different ways of assessing patients and treating patients so that we don't have any more of infections. In terms of maternity care, the bit that we need to highlight is across the number of caesarean sections, which is higher in St. Helier than at Epsom, which is again in terms of Epsom is lower than the 41% of last month, but still higher than where we would like it to be. And in terms of birth centre births, we still have St. Helier has achieved the 20%, whereas at Epsom is still below 13%, which is below where we would like it to be.
Okay. Shall I pick up the next few? There's so much information here that clearly what we're doing is just highlighting some key aspects. So in terms of friends and family, I think the position that we want to emphasise is that there's an increase in the inpatient reporting in month, which is a positive step. But actually what has concerned us is that the recommend score, if you like, the feedback that we're getting, particularly in A&E, dropped in month, and that is a real concern for us. We obviously are aware of the operational pressures and how busy it was for our patients in A&E, which may have impacted on this, but we're very keen to work with Health Watch, and I know Lisa is looking at how we can do that, to understand better what we can do to make the A&E experience a better patient experience for all those that attend. So those were the key points there. And I have to emphasise that the complaints response rate has really improved once again in March. Those of you again who come to the board regularly will know this has been really challenging for us as an organisation, and we're thrilled that in March 73.1% of complaints were sent out within the required time frame. Clearly we would like it to improve further, but I think the step change to get to 73.1% is really quite significant. So I want to emphasise that has been achieved by streamlining processes, which has been very successful.
Okay, so I'll pick up the responsive bit. So cancer, to the you can see that the 62-day target we missed in January and February. We haven't yet put in the March data, but I'm pleased to be able to tell you that we hit it again in March, and it looks like we hit it in April. So that's getting back on track. The really interesting, you know that we one of the national pioneers for diagnosing prostate cancer within 24 hours when you come. Because we're doing it, we've had a 140% increase in referrals for prostate cancer. So that's causing quite a lot of challenges about how do we see all those extra patients. But it's good to be nation-beating in leading the way in new diagnostics. In elective care for 18 weeks, you can see a slight improvement in March compared to February. The April data is a slight improvement again on March. To give you some sense of scale, we have 30,000 people on our planned care waiting lists, and that's a huge number. And we are ramping up the amount of planned care that we do because currently referrals are going up quicker than we can treat them, and the standard we have to deliver. So when you see April's version of the IPR is have no more people on the waiting list at the end of this next March than we're on it on the 1st of April, is the target we have been set. A&E, you can see that March was a bit better than February. Really, I think winter only finished after Easter. This year it really has been extraordinary, and then we've had a couple of weeks in the end of April, the beginning of May, where we were back up at 95%, and then the really hot weather in over the weekend has just caused an incredible amount of illness again. So, for example, yesterday we ran out of ITU beds. You're not supposed to do that in this time of the year. So there's a lot of very sick people. Workforce?
Yep, I can take workforce. So I think the key messaging here is that our vacancy rate went up marginally in March. There is a lot of work going on. This is across all the different healthcare staff groups to recruit to substantive posts, because we have had a very good track record in actually increasing the numbers of our substantive workforce. And actually, I think it is fair to say that latterly, we've recruited from a nursing perspective a lot of local graduates and a lot of local nurses who are returning to practice, which is a very positive thing for us. So there are lots of different initiatives underway to actually enhance our substantive staffing rates, and they will really continue through the late spring and into the summer. And as I say, that pertains to all of our staffing groups. Clearly, we monitor very carefully our use of agency, and are continually putting in place measures to try and minimise the number of agency staff we need to recruit, that we need to use. However, we will not compromise patient safety by not having those staff, and so there are occasions when agency staff need to be brought in, as you'll see from the graphs here. So those are the key messages really on workforce. Sickness absence continues to be above where we'd like it to be, but fell in month quite significantly, so that's a positive move. And I think the other parameters that are listed here are stable. What I would emphasise is that our statutory mandatory training in March was 85.7%, and is the subject of a very significant focus to make sure that all of our staff groups are actually able, through the, we hope, slightly quieter and calmer spring and summer months, get their statutory mandatory training up to date, because I think at times of peak pressure it's quite challenging for staff to be released and go off and do their regular training updates. So those are the key points there.
Then lastly, let's just do money. So you can see that March was a very good month for the money because the land sale at Sutton completed. We achieved the deficit position that we were asked to make for the end of the year. In fact, we did slightly better than that, and we ended up by getting paid a bonus for doing better than the control total. So as a deficit trust, as ever, that bonus is in theory supposed to go to pay off some of your deficit, but we have been given dispensation to use that to pay for some of the capital works to sort out the infrastructure in Epsom and St Helier. So when we do the next public board meeting and we talk about our capital plan for 18-19, we're now intending to spend £50 million this year on improving the critical infrastructure in Epsom and St Helier. To be by far the biggest amount of money we have ever spent. So yeah, that's the finance report. You've, I hope, got the risk register there as well with you. If you have any questions about any of the risks, happy to do that in the Q&A bit. That was that bit.
Over to you now, Daniel, to give us a strategic update.
So I was hoping to be able to share with you the CQC report because they had told us they were going to publish it on Wednesday. They're now publishing it on Monday. So we can't talk to you about that. We have seen it clearly now. They sent it to us last night. It is I will say it is a significant improvement on the last time they came, but it's still not as good as we want it to be. There's more to be done, but there are some really big improvements that they note. And I don't think I can say any more than that without getting into trouble with them. So they will issue their report first thing on Monday morning, so you can read it on their website. Another strategic thing that I can't quite say yet that I had hoped to be able to say was there's a bigger, the Sutton CCG are going to be announcing this afternoon about changes to how community services in Sutton are provided, and there's a whole heap of staff briefings happening this morning, and so that will come out this afternoon as well. And then a non-strategic thing, but something completely amazing, was Nurses' Day, which was 2 days ago, where we celebrated all the incredible achievements that our nurses have done. Yeah. Do you want to say something about that?
Yeah, absolutely. I mean, it was a really well-attended day. There was lots of energy in the room, and staff were delighted to receive prizes, and we based them on the qualities that we're looking for, so care, compassion, and so the staff received prizes for being able to demonstrate those, and as nominated by patients mostly.
And then other things that have happened. Jeremy Hunt came to visit last week to do a meeting about patient safety. He's been doing the rounds of all the hospitals to give a talk about how important that is. So he now has two things to remember Epsom and St Helier by. So he always now begins, when he talks about Epsom and St Helier, about the boilers at St Helier. And since he was doing patient safety last week, we took him into the simulation centre, which is on this floor, and he was completely wowed by the mannequins to doing the practice on, because the newest mannequin actually has eye movements as well as being able to talk. So Jeremy had a conversation with a mannequin that was actually pretending to be a real patient. So he's come to visit. Who else? Has anyone else come to visit? No. And the integrated care developments we've got for Epsom Health and Care and Sutton are really coming into their own. So in Epsom Health and Care, the stroke service, both the hyperacute and the community and the hospital service are now one team, and we're already beginning to see that we are being able to look after more patients in their home following their stroke, and so there's less time in the hospital beds. And the Sutton Health and Care service to mirror the Epsom one has now launched, and there's quite a lot of good feeling about that is going to make a big difference too. I think that's enough.
I think so. The only other thing I would say is that you probably noticed that there's now both a Marks and Spencer's and a Smith's on this site, and a Marks and Spencer's and a Smith's on the St Helier site. So a wider choice of shopping and eating and other opportunities for everybody. We're ahead of schedule, so I think really we could start to take some questions. So I'm sure you have a number of burning issues, so thank you.
This is my first attempt.
Okay.
And such, I'm marginally confused because I couldn't understand a word of this.
Okay.
I tried looking down. Could you please request do it as a slideshow, a video show, so that I can follow, you're following down here. By the time I've understood what you're talking about, you're 3 pages ahead. So I'm not blaming you, it's probably my fault because it's my first time here. but if you could use it as a slideshow, it would be awful helpful for me.
Right. I mean, I think we can think about that. Clearly, we'd have to prepare it and have the ability to
You've already
do
prepared.
decent. Yes, obviously,
Most
to do proper projection. But I absolutely take your point, and that's something we can certainly consider. Thank you.
Thank you. I'm Veronica Monks, and I'm a member of the local Labour Party. Just make that clear. I was interested in what Ruth said about complaints. It's interesting that you've made your administrative targets in responding. My question about complaints is what learning have you analysed from those complaints to make the system improve?
Absolutely critical question, so thank you. Lisa Thompson, who's exec colleague who heads up complaints, has really changed the way that we learn from complaints, and that's been aided by having a clinician work within the complaints team to go out with the teams and actually make sure that the response that's written to the family or the carers translates into real actions and change in how we do things within Epsom St Helier. So sort of holistically, the approach we take to the learning has really been transformed. The other thing that we do, so that's the generic answer to how we do things, but we have a multi-pronged approach to that. So we have newsletters that go out that will highlight learning from complaints, and we talked about simulation. So I work very closely with the simulation team, and recently I met with a complainant who flagged up an issue, and the issue they flagged up is now incorporated into a scenario that's run during simulation. So we try to be nimble and to think differently about how the learning can be shared.
We did have, there have been issues with complaints, and I think we've acknowledged those. One of the problems we always had was about the length of time it took to respond, so on the admin side. So we did focus on that to make the process much more efficient, and we've done that. And I think what Ruth has now said is we're building on that to bring in the clinical side and the learning side. So complaints is an ever-evolving journey. You're never going to fix it for everybody, but we really are trying to move it on.
Hiya, my name is Helen O'Connor. I'm from the GMB Trade Union, and I've got some question for you on staffing and also on planned changes going forward on the trust. So I'm just wondering what impact you think cutbacks have made on staffing, recruitment and retention and sickness levels in the trust, and could you outline what measures you're taking to protect the well-being of your staff and make sure that they're loyal to your organisation. Also, I wanted to ask about the planned significant changes in terms of the centralisation of acute care services. And there is a concern, I think, that many acutely unwell patients will have to travel further for treatment. And I'm just wondering what measures are being taken to mitigate against the increased risk to those patients in your planning. Thank you.
Ollie,
So
do you
if
want to
I
start off?
start with the staffing, I think, so I just joined the trust 2 months ago, and what has been really obvious to me is that there is a definite drive to recruit staff, nursing and non-nursing staff, and that to me is a change from where I've come from, where actually it was the opposite way around. It was like, we're going to manage this to the nth degree. We can, in this trust, recruit all clinical staff without having to go through a long drawn-out process, which again is what I was used to, and you couldn't get a band 2 carer on the ward without having to fill in 5 sheets of paper and talk to 10 panels. So I think that's really positive, and there is a system already set up where the chief nurse works with recruitment to ensure that continues, and that we are actively recruiting all the time into all of the vacant posts. I haven't seen any evidence of any cutbacks that have affected patient care, and there is a process in place that I know of as well, where any changes to services is discussed and is brought for a panel to discuss the impact on patients. So, is this going to be safe? Are patients still going to be safe? So I think that there are really good processes in place and checks and balances around, if we're going to take this money out, what's that going to mean for patient care?
And sorry, could you just comment on how you're retaining your existing staff, and also about the issue of band 4s replacing registered nurses on the wards?
So my experience and knowledge isn't that band 4s will replace band 5s. I don't think that's a,
It's kind
well,
of a concern raised in the document. that was
yeah,
sent to the end.
it's not a replacement, it's the use and improvement of the non-registered staff to complement the registered staff on the ward. So it's not a replacement. So we're not taking band 5 posts out to put band 4s in.
Well, I think
If
this-
anything, we are
just
looking at
Just looking at this document, there is a concern.
What document?
which
Yes,
document.
well, this one right here about staffing, there is a
Yeah.
concern at the bottom of the band 4s while waiting for their registration are actually on the wards as the.
So that band 4 registered nurses who have come from abroad. And so they need to, while they're waiting for their PIN number and going through the registration process here, we can't, they have to work as band 4s, not band 5s. So what they're waiting on is their PIN number.
But they don't have their NMC registration.
They don't have their
yet.
NMC
Yeah, that's the point
registration
I'm
yet.
making,
Yeah, absolutely. But they are qualified nurses in their own right, just waiting for our process to go through.
So I think the other thing on the band 4 bit, so you've got the nurses we recruit from abroad who are
Yes.
waiting for their NMC, but you've also got this really exciting development
Absolutely.
of associate nurses, where there is now going to be a career structure
Yes.
for unqualified people, the band 2s, to gain the skills and competencies to get into become qualified nurses, and we are right at the vanguard of recruiting people
We are.
onto those training programs. And it's either 20, it's either 2 lots of 20 or
Two
one-
lots of 20 as far as I
and
understand.
we are paying for the training of those staff, because what we noticed, so when we moved our admin building down into Epsom, it's right next to the job centre, and we spoke to the job centre and said, can we, are there people who are looking for jobs in healthcare? And they came back and said there are lots, but they don't have the skills. So actually what we're doing is using our local workforce at both the Sutton and the Epsom ends to bring in new people into the NHS and give them the training to create our own workforce, as opposed to having to have the reliance on overseas.
And temporary. And there are lots of opportunities with the apprenticeships as well. So using the apprenticeship levy to bring people in again to give them that support and training to develop. And the associate practitioners, it's now been agreed that they will be enrolled within nursing with the NMC. So there are lots and lots of activities around improving nursing availability for patients.
And then you asked about well-being.
Yes.
So we're really proud of all the
Yes.
stuff we're doing on the wellbeing space. So we're one of the NHS England exemplars in wellbeing. And so we have got things like physios to do extra back care, so that if you hurt your back, it's a very, very short wait to get training, to get it fixed. We offer everyone who's over 40 an annual health check if they want to take it up. We have had health and wellbeing days where we've had reflexologists and all the other people coming to talk, so we improved all the cycling facilities for people who wanted to cycle to work, so including new changing rooms and showers. We're doing our best. I think the thing the staff next one is a gym.
What a revolution we're listening to here.
But that's what's going on in Epsom and Helier.
Yes.
A complete revolution about improving the care that we can offer to the
Whole
people
way
we
of
serve.
obtaining staff, actually going to use people from this country, it's almost unheard of. What's going on here? You're starting it in Epsom. At least you can't be completely behind the times, and that sounds great.
You also asked the question, didn't you, about travel times? If we get a centralised acute thing. I mean, obviously, it's a very big if. It's several years away if it happens, but we do have a view.
Do you have a plan, do you?
Well, hang on. So let's just get the context of this right, because quite a lot of these questions are now not currently for us to answer. So we as a trust put forward a clinical model for how we perceive the future could be for Epsom and St Helier, and asked people what they thought about it. Which did involve consolidating some of the acute services into one place rather than two. One of the responses we got back was from our staff partnership forum, which includes your members, and they said they were supportive of what we were proposing as a clinical model because they could see that it will improve patient care. At Christmas, we handed all that over to our commissioners and said, well, this is what Epsom and St Helier would like. Now, you actually are the decision maker here. What would you like to do about it? And what they set up in January was the beginning of a programme to say they do want to take forward what we have been saying. And in June, it is currently scheduled that there will be a committees in common of Merton CCG, Sutton CCG and Surrey Downs CCG, who are the commissioners of the majority of our care, where they are going to have a meeting together in public to talk about what do they think needs to happen. So they're just finalising the date of that, and then then you will get to see what they think about the next steps should
Will there be a public consultation
So-
again at that point?
Well, so in their committees in common, they will say this is what they think, and if they think that they're in public that there is a case, then they will be initiating the beginning of a process to do a public consultation.
That's right. So I think right at the back first, and hello.
Talking about transport, I don't know if my friend has actually made a complaint, but I just want to give you sort of general situation that she was in. She lives near St Helier Hospital. She needed a day procedure that can only be done here now. I don't know what it was. But she was put, instead of being in the NHS bit, she was put in the private bit, even though she's an NHS patient, and she required patient transport. And I didn't realise this, and I'm not sure she's got it right, but she was saying that there's two different transport facilities, and when she was stuck in the hospital because the NHS transport refused to take her because she was in the private ward. I don't know what any of this, but I'm just worried about it. What she said worried me. And then
So she was an NHS patient who was put in the private ward.
She was in the bed situation, and then but the private people wouldn't take her home because she's an NHS patient, so she was stuck in limbo and was
Got you.
going to have to
Okay.
spend
So-
overnight. So they had to call in somebody from somewhere else. What can you do to alleviate such situation? Because she didn't want to be in a bed.
No,
You could use the bed for someone else.
that shouldn't.
It seems a very
shouldn't
serious
happen.
situation. So
So-
what would you be able to do about something like that?
So that sounds like an administrative
Yeah, it's
not right, because that shouldn't have happened. So we have a very comprehensive patient transport service. In fact, one of the things that we have just done with it is it was in the private sector, and because of the performance issues we were having, we have in-housed the whole thing. So 130 people who were working in the private sector are now working for Epsom and St Helier, while we decide whether actually the right answer for patient transport is actually the NHS is the best provider of it rather than using the private sector. So, and since we in-housed it at the beginning of April, the number of complaints has plummeted, and the performance has got much better. So,
Yes, I mean, I think in terms of your friend, if she wants to, if she would like to write or email then obviously we can investigate the precise detail of what happened, because clearly it shouldn't have happened, and it seems like she fell between the cracks. But as Daniel has said, we've reversed our a previous approach to patient transport, which was to put it out to contract, and we brought it back into the NHS, and it is actually proving to be so far a successful move.
Oh my God.
I know. So, Sandra, would you like to?
Yeah, I'll stand up so I can be heard too. Can I ask a couple of questions, actually, one on a subsidiary? Could you, Daniel, confirm that your plan in your outline summary case for change, you have listed 3 possible outcomes on page 14, where you show 3 possible outcomes for your plan? Could you confirm that one of those outcomes, the third one, actually entails the removal of acute services from Epsom and St Helier Hospital? Is that your plan? Or the camera consider?
so all 3 scenarios
Yes.
keep acute services in the catchment of Epsom and St Helier.
That's not the question I asked you. I asked you, does the third scenario involve the removal of acute services from Epsom
Yes.
and St
So
Helier?
I just answered your question.
No, you didn't. No, you didn't. Could you please answer the question?
I have.
Does your third scenario involve the removal of acute services from Epsom Hospital and St Helier Hospital. I don't know if you can all see that. The bottom one, no A&E, no A&E.
So
Can you confirm that that's
So I'm going to answer it once more, and then we're going to end this little bit of conversation.
Right.
All of the scenarios that we put forward to engage the public on maintain the full range of acute services in our catchment for the people of Epsom and St Helier.
I think, can anyone, is my question being answered here?
No.
Thank you. I'll go on to say that
Third
everyone
option.
agrees you've not answered it. There's the
No,
plan.
everyone did not agree.
Okay, a lot of people. There's the plan. No A&E in Epsom, no A&E in St Helier. I want to then, the supplementary question is, Daniel, why did you phone TfL about the posters that we bought and paid for and had put up, and tell TfL that when we said that your plan, you have a plan to remove acute services from Epsom and St Helier hospitals, you told TfL that that was a lie and had them remove our posters that we bought and paid for. You told TfL an untruth in order to get our truth removed from the public. Can you tell me why you did that?
So yes, we did contact TfL
You
when
did,
we
yes.
saw your posters,
Yes.
because we believed your posters were completely misleading, were not accurate, and were not a fair representation. And
As
when
a campaign group, by law, we do not have to be balanced or even. We simply have to tell the truth. And we did.
so
Here.
So what? So when we explained to TfL why we thought you were wrong, and we showed them, do you know what? They agreed, and that is why they took down the posters.
What
so
they said to us was they're not in a position to be judge and jury. They simply took your word
That's
over
correct.
our evidence.
So, well,
Which they didn't see.
they have a whole set of code policy about what adverts they allow.
Yes. And ours was cleared by them before your complaint.
And
it
we-
was cleared
And
by
we
them.
demonstrated that those adverts were in breach of their own policy. That is why they removed them. If you want to complain about it, you need to complain to TfL, and then TfL can decide what they want to do next.
We have complained to them, and they told us they saw our very compelling evidence, but at the time, because they couldn't act as judge and jury, they took your word over ours. We will pursue this matter,
Will be rescinded.
but we were telling the truth, and you were not, Daniel.
Any more?
So I was just going to make a comment that Daniel made at the end of that actually the Kosh's problem is with tip transport for London, and they can always pursue it through judicial review if they feel so strongly.
Yes.
Well, no, it's been objected to by this chap personally. That's what they told us. Let's have it understood what the question is and why we're a little bit, shall we say, out of sorts about it. And they say they will review it and it will be rescinded. We will come back to this at some point. You may want to come back to it through your Labour Party. Please feel free. Find out the facts first.
Okay. Beth.
I've got two questions. The first is, a couple of weeks ago, the lifts on the Wells Wing were out of order.
Yeah.
This caused chaos.
Yeah.
And I know you've got to fix it as soon as possible, but the small lift has been out for many weeks.
Yeah.
The only lift remaining is a fast.
Yeah.
It's very temperamental. People get in and it says this lift is out of service
Yeah.
because there is a fault on the doors. And if people don't know that they've got to push the door, then
Yeah.
they're stuck. I know it's been fixed, but you say it's a temporary fix.
Yeah.
This is the main
Yeah.
corridor.
So Bess, this is just such a classic example of the things that we need to fix in Epsom and St Helier. So those lifts were installed when this building was built. They have not been replaced since then. We thought we had as good a maintenance contract as you could get, because it has a 4-hour response time. We have never had all of the lifts breaking at the same time, and so in the past it has been okay, just about. But actually, those lifts have now come to the end of their serviceable life. To give you an idea of the cost, the part to fix the one that we've had a temporary fix on is £32,000, which we have ordered. And actually, what we have now decided to do is we're going to replace the lifts over the next couple of years. And in this year's capital plan, we've set aside somewhere between £300,000 and £400,000 to improve the lifts in Wellswing. But it's very complicated. In this building, there are only 2 lifts that can fit a bed in. If you are going to replace a lift, if you imagine, it's just like the escalators on the underground. You know, they close it down for quite a long time. So it's about 16 weeks to replace a lift. So if we close down one of the bed lifts and we rely on one bed lift for the whole building, what happens when it breaks? Because on current form, none of our lifts survive 16 weeks without a fault. So what we're actually investigating is building a new lift shaft on the side of the building to build a new lift before we can refurbish the old ones. And that's why it's going to cost in this year £300,000 to £400,000, because that's what we're going to do first. And this is just a microcosm of having decades of not enough investment in our buildings to keep them fit for purpose. And that's why when we say this year we're going to spend £50 million on our buildings, we really are going to spend £50 million on the buildings, and nearly all of the expenditure is on things that actually should have happened in the last 2 or 3 decades. So you're not making a massive improvement in the patient environment, you're just making the buildings that we have kind of like suitable, serviceable for healthcare. But we were really devastated about the lifts all not working, because we clearly caused a huge amount of distress and inconvenience for everybody. The only bonus was more staff walked up the stairs, and so got a little bit fitter. But in the context of how many patients and people who weren't able to actually get to where they needed to be, it's tiny.
Okay, we're going to get, in a minute, we can come back to more questions later. We're going to get the report back from our 15 Steps Challenge, because a number of our non-exec directors have been walking around the hospital this morning looking at various parts of it, and are going to come back and report in about 3 or 4 minutes' time. So I'm just going to take one more question now, and then we can do more questions after we've had the 15 Steps Challenge. And David, you had your hand up.
Thank you. At a previous meeting, I had a complaint to make about the fact that you have prevented us from recording and filming these meetings, and you have failed to provide audible and intelligible records in those recordings of questions from the public. And you have failed to report those questions and answers in full in the minutes of your report on those meetings. Can I ask you that you fully minute this meeting and include all the questions, including the 2 that were put to Daniel, which he failed to answer satisfactorily?
So what we have decided is that we are not going to minute
what a surprise.
the question and answers from either these or in the public board meetings, because in the way the board meeting is constructed, they happen after the board meeting has closed.
This is a public briefing. Do you not want the public to know what's being said?
Well, that's why we're recording it, and it will be on our website.
It's inaudible, and you don't include the questions in the minutes.
However, we have also reviewed our policy on whether people in the audience should be able to record the meeting, and you'll be really pleased to hear that we have concluded that if you want to, then providing no one in the audience objects, then
We
yes.
never record the audience, we only record you.
Then you
It would have
can.
been helpful if you'd have let us know that beforehand. I wonder if that had anything to do with your anticipation of a difficult question.
Right, I'm going to move on to the report back from, Elizabeth's here, and Rakesh. Where are the others? Go and get them. Because,
Can I just say I do object to having the audience questions recorded, and I think there is a recording going on currently.
we always have recorded the whole
No,
meeting.
by an audience member.
Oh, by an audience member.
So, well, so I think you should not do it then.
Everyone in this
Be a
room
different
could be
recording,
recorded.
wouldn't it, absurd?
The
No, it's all I was going to point out to people. Under the Data Protection Act, they've been enforced that you have to get people's agreement. Does this
So having looked at the law in much more detail, I think it is hard to say that as we are a public body, that members of the public cannot record meetings where we invite them to. But if people in the audience object, then actually we need to take that back, because I don't quite know how to respond to that.
But then isn't that an argument for limiting the questions?
Well, we don't wish to minute the questions because we're having
we're always very clear actually in the board meeting that the board meeting ends, and then we have questions.
Well, so
if people can object to having recording, which as far as I'm concerned is fair enough. But for transparency's sake, wouldn't it then be helpful?
Goodness me, just take notes.
Yeah.
the
I don't understand. I don't understand. You've been filming these meetings for months now and stopping us as the public who own the NHS from seeing what's being said in a public meeting. I don't understand why anyone at a public meeting should have any problem with it being recorded. It's in public. What's the problem with it being recorded?
Well, I think there are a number of areas, aren't there, Sandra, where you can't, for example, film school plays or anything like that anymore. Well, you can you? Oh, I thought you couldn't. No, you can't. You see, so nobody knows.
Sorry, I've got children at school, and you can, and we do.
Okay, all right. Well, I was told you couldn't buy it. Yeah, okay. Look, can we? I'm just going to pause this now. Yeah, I'm pausing this. I'm pausing this now because we're going to go on to the 15 steps report back, and there'll be a little bit of time at the end of that for a few more questions. So, would you like to come up so we can hear you and see you? Thank you.
I'd also like to ask whether I can take a photo of you all. We have never had so many people at a public briefing.
You're filming it now.
Yeah, but that's from the back. And this is quite a wow moment to have such a large audience. So,
right. So, we're going to have 15 steps. And is it only you two?
No, they were there, they ran away.
They ran away. All right.
They were like, I think we got really engrossed on our 15 steps. You sent us to a couple of wards each, I think, Chairman. And we,
Right.
quite
Elizabeth, you went to Bradbury Ring.
Yes, which is the outpatients diabetes clinic. There was an obstetric diabetes clinic in full swing. It all looked very organised. Obviously, big with all outpatient clinics, as I expect you all know, very frustrating for people when they do overrun. And one of the first things that we noticed as we walked in, wasn't it, Charlotte, was that there was a big poster on the wall which said that if you have additional car parking charges because the clinic is overrun, to talk to the receptionist because she can help you out. So that was a very positive message to see straight away, and very realistic. We had a long conversation with one of the clinical nurse practitioners called Paula, and she was telling us that the most important thing for people with diabetes is the education program about managing the condition themselves. We run those programs internally here. We have spaces on them for about 20 people. They get fully booked by 20 people, and then on average 3 people turn up. And that is so frustrating for the team, because that obviously the team have set aside their time, they booked the space, the rooms and everything, but it is so important for people that they learn to manage this condition. And so this is a great opportunity to say to you guys, if you know of people, do encourage them to come along to those learning sessions. Anything else you wanted to add?
Well, I was just surprised because it was a gestational diabetes clinic, how busy it was, how many of our ladies are getting diabetes, and apparently if, one
4 might have some problems afterwards, later on in life, which was higher than I expected.
Do you think the rate has gone up?
Yes.
During your sort of nursing career, which is a year or so?
Yes. Last year, thank you, God.
Yeah,
Yes,
okay.
definitely.
Yeah, interesting. And presumably there's been research into the reasons for this, or is it lifestyle? Is it just?
It's lifestyle.
It is lifestyle.
Yes.
Yeah. Yes, very, very, very interesting. Right, let us continue. Pat, you went to ED.
Yes, I went to ED with disappeared Kevin and Dan. So we went first the way a patient would come in from the car park. The signage there was quite clear that that was the way in. There was only one way that you can go, and then triage will happen. So that then they were directed to some other part of the unit. It's all under construction still, so it's full of men with toolboxes. But it's very airy. It's got a new screen up to provide some interest while you're waiting. We did ask about there being more indication of how long the wait might be. There was a notice up, which was obviously from last night, which suggested rather a long wait last night. But that is not the case this morning, where there were quite a lot of people queuing at the desk. The rooms are all very nicely, although they don't have natural light in minors, they're all very bright. The colours of the walls feels fine. We then went through to majors along the corridor. One of the problems at the moment is that the signage for X-ray, because if you go from minors and you need an X-ray, you go along the corridor, the first thing you see is X-ray for swelling. So that will be adjusted, but at the moment there are dots on the floor, so that you're told to follow the blue dots. And X-ray is not in its final position, so we can't put permanent signage up yet, because it will be wrong in a few months when that's complete. So we went into majors, which felt so much better than the last time I went there, because it has air conditioning. I think it was summertime the last time we went in, and it was a completely different experience, which was very nice for the patients and the staff, obviously. And that has been completely redesigned. So we've got the main desk, and we've got all the beds where they can be seen by the staff at the desk, which is, I understand, best practice. Absolutely. And we want to repeat at St Helier. And it certainly was very obvious, what cubicles were full, whether there were relatives there, and whether the doctor was there. And the whiteboard was an absolutely vital tool for seeing who was the most urgent to be seen by a doctor, or who was seen and who was going to be admitted. So that was all very, very clear. There was full staffing this morning, which was nice to see. And the clinical area manager, Amelia, told us all about the plans and how she'd been involved in the reconfiguration of the area. And some of the longer term staff were saying how much better it was now, how happy they were to work there. So that was all really good. And I think I can safely say that the unit was working very well. It was busy, but it was calm. And if we can get the miners like that, so that we don't get the miners referring or clogging up and producing problems in majors, that would be great. The area does provide enough room for ambulance offloads, so there aren't ambulance rates, which is good to hear. Anything else, Dan? Kevin?
No. Good.
Could we not have had a handheld mic? Because I didn't think I was hard of hearing.
I'm sorry.
No, it's not you in particular. It's everyone.
No, it's not.
No.
So normally we do,
Yeah, I know.
but not, it's not normal to have.
But a handheld.
It's never audible
Well,
on
the
your
board.
No. The lady's talking about in this room,
In this room.
we never normally have so many people, which is why I took a photo.
Yeah,
So
it's a handheld.
so next time we will have to have a mic for both the public briefing and the board meeting.
I apologise though,
No,
if I was not
it
clear
wasn't
enough.
just you I was aiming
Yeah.
at. It's just that I thought. I'm not
You could come to the.
I didn't think I had a-
Would you like to come to the front?
a hearing problem.
That's what me. Did we get permission for you to photograph everybody?
Right.
No, serious. That's a serious question, Daniel. You're asking about whether we should record you. Did you ask our permission to
Well,
take our photograph?
I think I did, and no one said no. But
You didn't, and I didn't hear it, so let's just...
Could we have a legal judgment on this matter and stop all this argy-bargy?
Well, Lisa is now here. I think she
Yes,
was here.
yes,
Lisa
yes,
is
yes.
Lisa is our director of communications, so she knows more about these matters than anyone else. But the question is about recording the meeting, which we do, and some people think that they should be able to record it. Some people in the audience have said that they would object to being recorded by other people, and it's all a bit of a confused picture. And if you do have any insight as to the, if you like, the NHS policy on this, I think people would be grateful for it to be shared.
I think, Chairman, the policy is that the meetings should be recorded, and that's why we do the video in the room, to respect, I think, the fact that other people don't like being recorded. So that's why I think you'll find on our website and in our minutes, and hopefully there's a notice somewhere in the room, because it's not our normal room, that you do have the opportunity, you know, that we will be recording the meeting, but we do it so that the camera, if you like, is on the public.
Backs.
Yes.
Backs of your head. So
yes.
should I take the photo from the back?
So,
NHS England have said that they approve of, in the cause of transparency, they approve of audience members being able to film and record public meetings in NHS premises. That's NHS policy.
So that's what I said to you,
Yeah.
right? But I also said, but if someone in the audience is going to object, then what we don't know is then what you do. Okay, so we need to take back and ask that question. That's where we got to in the last bit of the conversation. So let's now close this bit down, and we'll go back and.
You are still filming.
I can see a red light, so yes.
So if you're filming, presumably I can too, because it's the same thing we're filming.
So that's what I want to now go and check, right? So, I thought we had bottomed it out, but we have a new question we need to go and answer.
So I think in answer to your question, it's a live question. We're going to take it away. We'll come back to the next public board meeting, and we will give, hopefully, a definitive view. Right.
You will get a legal...
Yeah.
This will be the view from the...
Yeah.
And we need to take all of these issues into account. Right, I'm going to continue with the feedback. Bess, we'll do questions later.
Just add something to that. I had an event recently, and there was someone complained because they were photographed, and they were told that they couldn't do anything because it was a public place and it was for security, and that was in the Ashley Centre. Someone objected to their child being photographed. They apparently saw it on the CCTV.
We will come back at the next meeting with as much of a definitive view as we can. Can I go on to Martin, please?
Sure. I'll stand at the front. Can everybody hear me okay?
Yes.
Okay. So we went to two children's wards. The day surgery ward, Casey ward, and Epsom ward, which is for those staying in hospital. Both of them were relatively quiet. I think in the first case more the time of day than anything, and very well organised, very clean, very tidy. Staff were very open and comfortable to discuss things. There was quite a different situation between the two, in that on Casey ward we talked about staffing. They clearly had significant problems as a result of the pressures on the NHS during the winter months, which meant that at times they had to close and cancel while it was being used for the overflow from A&E and the higher level of admittance, which obviously causes a lot of disruption, and they had staffing problems. In Evesham ward, it was fully staffed, and they didn't consider there were any issues on staffing. Again, it's quite unpredictable, so there are relatively few patients in there at the moment. But again, we were very impressed with it. We also met one of the people from the charity Momentum, who's done a lot of work, and really impressive new room where they decorated it, provided quite a lot of toys and other activities for children. Is there anything else anybody wanted to add?
Would it be
Yeah,
okay?
sure.
Shout if you can't hear me, it'll be a first. If I could just say, what was really interesting about Casey when we talked to the staff particularly was the numbers. They were saying a significant number of patients that they're now seeing who are self-harming, and the staff are really kind of worried about that. And I know there's a lot of work going on in communities to support young people, but it was really apparent when we went onto the ward that feedback we were getting. I mean, it was a beautifully done ward, very clean, very well staffed, but they were saying that the issues that brings is quite challenging when you're trying to manage somebody who is suffering, and they weren't just saying traditional, there is such a thing as traditional self-harm. They're seeing a huge rise in the number of anorexic patients, young anorexic patients they were seeing. So I thought you might be interested to hear that the change that we're seeing in terms of the types of patients we're caring for and treating. We did get the opportunity to meet some of our younger patients, and that was quite fun. Particularly 3 who were just about to go in for an operation, and they gave really positive feedback about the nurses and the environment, and they've been playing. The only criticism they had, which made me laugh a bit really, the only criticism they had was they were hungry, so I did promise them ice cream after their operation.
Good for you, Lisa. I think that's a really important point about self-harm. I don't know whether Ruth, as a paediatrician, can comment, but it does seem to me that one of the issues and problems that the NHS faces has been historically over the last 4 or 5 years a real reduction in the child and adolescent mental health services, and I know around here there have been some issues on that, and I'm just wondering, do you feel that we're getting sort of some of the blowback from the way that CAMHS has had issues and problems?
So that is quite a big issue in Surrey.
Very
and I sat at a meeting last week, which is the Surrey STP, the strategy board for Surrey, and we agreed collectively £1 million investment in child and adolescent mental health services to reduce the waiting times.
And it's a national issue as well as a local issue. Really resonates for me as a paediatrician. And I think it's a complex piece. It's multifactorial, and it actually goes right back to looking at how we have social media used, what's done in schools. There's a whole heap of emerging strategies to actually tackle this issue, because clearly hospitals should be a place of last resort for a very small number of young people.
Are they getting there under these?
You just can't get into these places. You can't get outpatient treatment. I've unfortunately got family experience trying to get a child mental health care, and it's virtually impossible.
So
it takes years to our heads against the wall. This is why you're having these problems here.
So I think as Daniel says, I think that is now recognised. I think there is a much clearer understanding of some of the root causes, and that we are now starting to see investment both nationally and locally into the services that are available in the community, because as you say, waiting for an outpatient assessment at such a difficult time is really unacceptable, and actually prolongs and exacerbates young persons and the family symptoms.
Right. Ian and Richard, I think you both went to Swift, is that right?
Yep.
You come on up.
Right, so we went and visited Swift Ward, which is an elective surgical ward covering full spectrum of surgical specialties. When we visited there, it was actually fairly quiet, had an air of calm efficiency about it. Something the staff observed was that it was a really busy day yesterday, and we're having a quiet day today. So in terms of planning of activity going through, there seem to be peaks and troughs. Stable nursing staff, they said they're pretty much up to establishment, very little use of bank and agency staff apart from at night, and morale seemed good on the ward. Their one complaint, as it were, when we ask them is that they don't like being moved to other wards when there are staffing problems there clearly. So they like being working with their own team.
You've got to solve this one.
Yeah. So in terms of the sort of basic infrastructure aspects, 3 drug trolleys, all locked, but only 2 out of the 3 chained to the wall. So that's what we're going to pick up. But in general, everything that needed to be secure was secure. I spoke to one patient, but I managed to pick up one of the medical outliers in the ward. So there were 3 medical outliers in the ward, but that didn't seem to be too big an issue from the nursing staff perspective and didn't seem to be interrupting surgical flows. What she did observe was that she'd been in 6 different places and submitted to the hospital 6 weeks ago, and that was something that she found disorientating and having to get used to a new group of staff each time. She had confidence in the staff on the ward, but said that the food, the menu seemed to promise something slightly more enticing than actually appeared on the plate. So she wasn't all that complimentary.
Like most restaurants, really.
Richard, do you have anything to?
No, I think I covered it. Thanks very much. There was a grumbles about the windows.
Yeah. So we've also, on the window front, we've also got in the plan for starting this year at Epsom to spend £2 million replacing the windows in this building and actually in the new buildings, which are also not in a very good state of repair.
Absolutely, yeah. They do less a lot of area and they're difficult to shut in the winter, we were hearing. We've got a scheme to change them all right around the Wells wing. We have to get planning permission for that, and we're just going through a process of approaching that planning permission. But I think that would be a big step forward for Wales building and Wales wards in it.
Good. Well, sorry, Charlotte, yes.
Ian, did you check the oxygen in the airport?
I did, they were all absolutely fine.
Good, thank you very much.
Good.
Could I ask Elizabeth, she said that 3 of her 20 potentially students didn't, only 3 turned up, so that was 17 people.
That's
what are you doing about it? I mean, that's appalling.
Well, so I did ask Paula, the clinical nurse specialist, when I was with Elizabeth, whether these patients are covered in the GP surgery, because I know that they do a very good education package within the GP surgeries with their sometimes our CLSs and their own nurse practice nurses educating the patients. Her understanding was that there was a poor uptake within the primary care too, but that's something I'm going to take back to check out with the CCG, because if we're having poor uptake on both sides, then we need to change how we're doing it.
Yeah. My dentist phones me the day before and says, "Don't you dare forget it."
Well, yes, I mean, we have that kind of system.
Yeah, we phoned people the day before and
Still
texted them.
17 days.
So I think it's different for an appointment to education. And if you stood back and said, what is the social contract the public have with the NHS? I think there's a whole series of conversations we need to have, which says, so you're paying your taxes to get a service that is free, but actually you have a whole heap of responsibilities as the public about how you use the NHS. And for all the people with chronic conditions, there is lots that we can do to enable people to look after themselves better, and I think we need to get much better at explaining to people that if you want the NHS to carry on, which everybody does, we have to get into how do we use it responsibly, because the level of demand is really, really far outstripping the level of supply that the NHS can deliver. And quite a lot of the healthcare needs come from people not looking after themselves as well as they could do. So we need to get into a much better space where people are encouraged to want to look after themselves, and then the NHS provides the support to enable people to do that. And I think that is a we can have the conversation with our patients, but I'm thinking I should be feeding that back up the line.
Yes.
Actually, the NHS needs a conversation.
Absolutely.
With the public.
The government, it stems from government who can only go after that.
So I'm thinking I will take that back.
But surely there's a lack of responsibility. If people make appointments and don't keep them, unless they've got a good reason and let people know. I mean, I consider that very bad manners for starters.
You know, three out of 17.
Yes,
Yeah.
so for appointments,
Absolutely awful.
our do not attend rate for outpatient appointments and procedures is very low. And in part it's very low because we do the thing that the dentists do, is we text people to say, remember your appointment. We're in a different space with the education programmes where people aren't perceiving them to be as important as we think they should be.
But you get at RTPs, I've seen sometimes about 250 missed appointments in a month.
Yeah.
I think that's awful because lots of other people could have gone in that place.
Yeah. Right, we've got about 15 minutes left, so let's.
I just wanted to make a comment. A comment about this education. I had back-to-back appointments at Norfolk up at St George's yesterday. The trouble was, the night before, I'd gone to meet friends, and I stupidly got a lift, well not stupidly, someone gave me a lift home, left my bag at the venue, so I got no money, no debit credit cards, no bus pass or anything like that. I spent hours trying to get through to Moorfields because nobody answers their machine and their phones to say why I couldn't. Fortunately, a friend rang me with enough time for me to get to, but because they were back-to-back appointments, one of the appointments I really had to give up on. They are aware of it, they are, but I mean, situations like that, I didn't do it deliberately, and fortunately, I did get there. But it's on the reception desk, there's never, and I've written to Moorfields numerous times about trying to change the appointments and the times they make them, because you never get an answer.
No. I think I think there are obviously Moorfields isn't us, but there are lessons I think for all healthcare providers. Right.
Yeah, St George's needs a bigger car park as well.
Did you have a?
Rachel.
Yes, Rachel.
Right. Could I just go back to the mental health and the young people self-harming? Yes, we have got a problem in this area and surrounding area. I sit on various mental health things, as well as county and borough. Surrey Downs has just taken, you were at a meeting when the new chief exec or medical person, Dr. Hills, said that they've just taken on a mental health nurse. They know they've got this problem with the young people. Surrey Heartlands know they've got a very, very bad problem. Surrey Borders have now opened, they only had one in, for young people, they only had one in Guildford. In February they opened one in Staines, a centre for young people to go to. In March they opened one in Redhill. Now they're opening one, or just about to open one, in Epsom, where children can go after school and at the weekend to help them. And these young people, Safe Havens, are working with the Safe Havens for the older people, which function from 6 o'clock till midnight every night, and a roaring success. We at County on Health are very, very concerned about it, but we have, as Charlotte knows, a tremendous amount in this area. We are one of the worst in the country. In fact, at one stage, you were the second worst in the country.
Charlotte?
Yes, you're absolutely right. So last year we were given additional money to employ our own CAMS outreach nurses, if you like. So Lorna Bramwell's our head of nursing and paediatrics, who you know. We have 2 Band 6s who now work on site, and they go to A&E, and our auditors, so they're our nurses, they're on pilot for 12 months, they are trying to stop the number of children that are then admitted to Casey, which is interesting when you say Casey was quiet, I'm wondering if that was the impact. And they have been referring to these new centres because we've had a conversation about it. We've actually got a very good audit that says they have reduced quite a number of patients being brought in, and I wonder if it's something that we should take to PSQ for the future.
And the other thing is, Chairman, we're working with a lot of the schools, and we're hoping that all the boroughs will. We've got what we call youth councils, and they're working with the schools, as I say, working with various other mental health charities going into the schools. It's terrible. We've got to look after these youngsters because they're going to be a drain later on, and also their well-being.
Okay, thank you very much. So we've got 3 more hands, so we'll go there first.
Can I just ask this lady, are we talking here teenagers?
Yes.
Or
We are talking
even younger? I'm
teenagers.
suddenly thinking this might be a
In
primary
every
school
classroom, in every classroom in the school, in the country, there are at least 4 children with a mental health problem from the age of 5. It's-
5?
Exactly. We're not going into this subject now, but it is such a serious subject. They are self-harming from when they just get into double figures, and it is so, so terrible. And a lot of us are doing everything we can to improve, to help them and support them.
Do we have any clues as to why it should be so bad here?
Well, so that's a piece of work that public health
Yes.
needs to undertake.
But they're already on the case,
Yes.
I know.
Right, at the back.
I did want to return to something from earlier in the meeting.
Yeah.
You mentioned there's going to be a meeting in June, which I look forward to, about when we're getting to the plan for the hospitals. But in answer to one of the questions that was put, the answer was given that whatever happens, we're going to have acute services for our catchment. Well, looking at the strategic outline case, that's not strictly true, because if it goes to Epsom, the catchment will fall from 490,000 down to 295,000. If it's at St Helier, it will fall to 369,000. And the third option, which is the most generous, but we do lose the acute services at Epsom Hospital and St Helier Hospital. If it's put at co-located, then 70,000 people, more than 70,000 people, will be out of catchment. I understand the trust plan will provide for them, but it will be in other hospitals. Kingston, St George's, so I wanted that to be clear if we're looking forward to a public consultation about it.
So if the CCGs decide that they do want to go forward, and they do a public consultation, they will have to demonstrate how acute health services will be provided for 492,000 people, which is our catchment, and however we do it, some people will find their acute services in a hospital that is slightly outside the catchment.
But I think it's very important. I'm sorry to interrupt, but you did say
yes,
that
but if we
are providing acute services for our catchment.
I did say that, and that is completely true. But if we carry on as we are, we will be providing services for no people in our catchment, because it is not sustainable to carry on with the clinical model that we are currently operating. That is our contention. That is what we have given them for the CCGs to say, do you agree? And if they do agree and they decide that they need to do something about it, then they are obliged to work out how do you best provide acute services for all the people who currently use Epsom and St Helier. Epsom and St Helier's intention in all of this is we want to carry on being the acute provider for as many people in our catchment as we possibly can, and we want to do it from a modern, fit-for-purpose building that enables us to deliver the highest standards of care. And that's why you will see that none of the options that we put on the table involve not having acute services in our catchment. And one of the things the CCGs have to consider is whether they believe that to be a correct assumption.
You didn't provide evidence to back up your contention that if we don't do one of your 3 options, you will end up with nothing. There's been no evidence offered to justify that claim. It's simply an assertion to swing something like that.
So we think the case we put forward is very strong, and it's based on 3 things. It's based on we don't have the workforce to deliver the quality standards and can't see how you could conceivably recruit to them. We don't have buildings that are fit for purpose for providing 21st century healthcare, and to sort them out you need the best part of £400 million. And if you are running at a deficit, as we currently are, no one is going to give us £400 million. So you have to come up with a clinical model which enables you to deliver the quality standards. You have to have buildings that are fit for purpose for the future, and you have to get yourself into a financially better position. That's our case for change, and now we need to see whether the commissioners have a case for change which either agrees with our case for change or is slightly different.
So where's the costing for making the buildings fit for purpose and recruiting the necessary staff?
So,
Where's the evidence of that?
so if you went and read the documentation we put in the public
Daniel, you know we've read every word of it.
well then if you go
I'm
back
not
and
talking
reread
out
it,
black and white.
you will see there is a base case. And in the base
There is
case,
no case.
you say that what happens if you carry on as you are now and you miraculously get the money and you could recruit the staff, what would happen? And that is the base case. The problem is we can't deliver it, which is why we're saying you've got to make some change, and that I think is enough.
So just on this point about expenditure, I suppose as much as being made about the buildings and the state of the buildings, and I suppose what people wouldn't want to see is lots of investment in buildings at the expense of delivering services, because what we need is beds in local communities that people can access, you know, and again there's a real genuine concern I think in this room about acute care services being centralised, because that will mean very sick people will have to travel further, and we do need answers about how that risk is going to be mitigated, you know, in these plans going forward.
Yeah, I acknowledge your point. I think that as we've said, we've made our outline case. It now goes over to the commissioners, who will be looking at it with their eyes, not our eyes. And of course the commissioners will look at it in a context of other places that they also commission. So they'll be thinking about it in the context of Southwest London and this part of Surrey as a whole, rather than from a, if you like, a lens that we might have. I mean, I look forward to, obviously, to hearing what they say and reading what they say and discussing it with them. In any subsequent public consultation, it is quite clear that transport issues, travel times, and a lot of other things, areas of deprivation, ability to get staff, and so on, all of those are effectively mandated as areas that will be fully consulted on and fully studied. So I hope that you can be assured that nobody is trying to, if you like, push this through without consultation. These matters will definitely be out there on the agenda. So if the CCGs decide to take it forward, there'll be quite clearly many opportunities to talk about all of those issues.
And I hope people get a chance to have their say, because I'm aware that people in the room.
Well, no, I think the whole point about public consultation is just that it is the public.
It's
non-binding.
I thought I'd
The
put
br-
my hand up now.
Yeah.
Because otherwise I'm not-
In fact, you're going to be the last person to
Thank you.
speak today.
I'm so glad. Thank you. First of all, I'm Tina Mountain, and I'm the Borough and County Councillor actually for this part of Epsom. First of all, I want to say thank you, because there were complaints about the waiting area. If you were waiting to go to a ward or waiting to go to St Heliers, sometimes at 24 hours you'd be waiting. And I understand there are now beds in that area, so at least people are on beds, whereas before they were just kept in chairs. So thank you for that. You listened and you did something about it. My main concern is, and my residents' concerns are, that it is sale of land in Epsom, as I'm sure, Daniel, we spoke about it some time ago, particularly when the admin offices went to the building, I think it's in East Street, which actually is owned by Epsom Council, so good in there. You said that you hoped and you expected that any land sale, because the buildings won't fit for purpose, would remain within the National Health. And I remember that very well, because I couldn't get my head around why one part of the National Health would actually sell to another part of the National Health when it's all the National Health. So could I please have your assurance that any land that is removed from the Epsom site will still remain within the National Health and will not be used for commercial or residential development, because my residents are deeply concerned about it.
So I can't give you that assurance, and I don't think I ever have given that assurance in the past. So the way this process works is that if we, as we have declared that some of our site is surplus to our requirements, so that we can see there is no need for it in the future, which is what we have done for part of the Epsom campus, then the way the process goes is we put it on this thing called the public sector surplus land register, and the public sector gets essentially the best part of 2 months to say, we would like to buy the land. and the public sector includes your council, the county council, any other NHS provider, for any part of the public sector, the prison service. They can all say, we have a need for that land, and you get first dibs essentially at buying it. If there is no public sector interest, then it then goes to the commercial world to say, would you like to buy it instead? But the reason why the public sector comes first is because potentially the commercial sector could outbid the public sector in terms of how much money they'd be prepared to pay. So to stop that happening, you don't get to go to the commercial sector, and if the public sector are interested. Now, I can tell you that so far there has been some interest from some parts of the public sector, so we shall see whether that comes through in a bid. But the rules also say that for our hospital, we have to get a fair value for the land that we sell. So it will be valued by the district valuer. He will say it is worth this, and if it is sold to the public sector, that's what the public sector provider has to pay. Because we are all statutory bodies that all are required to get value for money for the assets that we have, and there is no way round that.
We understand that we sell land, but I think what my residents are concerned about, that when you have, as we can see, a vibrant hospital, how on earth can you justify selling land when you could when you could actually expand the hospital?
Well, we are actually, as you probably know, Surrey and Borders Mental Health Trust left the Woodcut wing, and later on today, Langley wing, and later on we're going to be hopefully approving some big expenditure to refurbish that. So actually we are refurbishing other areas which we didn't have. So we are expanding Epsom Hospital. I think one of the problems with the areas of land that Daniel was talking about, I mean, I'm sure you know it, but you know, some of it is in a very poor state, and to refurbish it will cost a vast amount of money. So we are expanding, we are moving into the area that Surrey and Borders have vacated. So it's clearly a balancing act, but we have a view as to the areas that we should be going into, and that's what we're going to be doing.
I think, again, the public find it difficult to understand that you've got this area in Sutton where you're going to build this brand new hospital.
Well, that's not certain at all.
Well, no, it's not exactly. That's exactly our point. So you have an opportunity here at Epsom where you could still build your.
Well, no. I have been assured, and the board has been assured, that even if we sell the land that we're talking about, if the results of the work done by the CCGs and the public consultations say that a new acute facility should be built at Epsom, then there is enough land here to do that. And that's quite clear, and the board have been quite clear on that.
Would it not be better then just to put it all on hold until that decision is made? Because once you sold it, it's gone.
So if there was a connection between the two things, then yes, but there isn't. Because the place you would build the acute facility on this site is at the front. So you would do it on the front car park, and you would demolish Headley Wing and put it on Headley Wing. And the reason why you would put it there is because you need to connect the building into the buildings that we're also going to be using. And the big buildings we want to carry on using are the new ones over there. So if you build your acute facility at the back of the site, you can't actually connect it to the rest of the hospital.
When the population grows by 24%, where are you going to put everybody?
Because we have modelled all the future demand for healthcare that you could conceivably have in Epsom, and could you fit it into the site that we would retain? To which the answer is yes, you could. This is a really, really underused site. So not only are we bringing Langley Wing back into service completely for the hospital, there's the building at the back, which was the Woodcut Wing, which was entirely derelict when I came, and now the ground floor is cardiology and eyes. We're now spending £2 million kitting out the first floor to make it to be the outpatient centre for Epsom, and Swelliok is taking the top floor. And so we have worked out all the buildings we need to bring back into life to make them really good for patient care, and we still think that we've got land that we can conceive of no use for. So what would you do with a 1930s house in the middle of a car park? What do you do with a boiler house that is got the steam turbines in it for this site when you've replaced it with a gas-fired set of central heating and in the basement of this building? What do you do with a residential block which has been condemned and now no one can live in it? And what do you do with the...
Expand wards,
But-
operating facilities.
Yes, but you need to do that in buildings that are in the right place on the site. So
You've just been saying that you're struggling with the problems that have accrued at St Helier with these lifts, etc., from underinvestment in the past. You're merely reiterating that and doing that same problem again and creating problems for people in 20 years' time. Now, I know I won't be here, you won't be here, and we can go back to various people over the last 20 odd years at St Helier. Now, that doesn't seem to be a very progressive way to look at it, to pursue the same policies you were complaining about before, and raising problems for them in 20 years' time. Now, come on, be a little bit mature about it.
Right, that's we will in terms of the land here, we will see, as Daniel has said, we do have interest from the public sector. We can't, obviously, we haven't got to the end of the period yet, so there may be more, or it may not transpire, we don't know yet. Obviously, once we get to a position whereby we can tell you more, we will do that.
But you're already pressurising the council in Sutton to allow you to change the use of the land there so it can be sold for housing. So you're trying to bypass this whole public sales. You're demanding that Sutton allows you to sell land in St Helier for use as housing.
So we went through all of those questions at the last meeting, so we don't need to rehearse the answers again.
Right, I'm afraid we have run out of time. Thank you all very much for coming. It's great to see so many of you. Oh, Beth, I'm sorry. All right, last one, very quickly.
My chairman and I had a meeting with Trevor about equipment being provided to Epsom Hospital by our charity. 7 months later, we're still waiting for a reply. I think that's a bit disgusting.
So I think we've
replied, Beth.
And we've resolved it and got to an agreement.
No.
We'll take that one offline, but I believe we have sorted that out. Thank you all very much for coming, and hopefully we'll see you next time.
Thank you all very much.
Complaint.
Thank you.
You would address it, well, if we go, you would address it to the complaints team or to Pal.